So now we're going to discuss asthma. We're going to talk about the definition of asthma and the pathophysiology. Asthma is a complex disorder characterized by variable and recurring symptoms, airflow obstruction, bronchial and hyperresponsiveness, and an underlying inflammation. The interaction of these factors determines the clinical manifestations and severity of asthma. The interplay and interaction between air inflammation and clinical symptoms and pathophysiology of asthma and the response to treatment. The working definition of asthma is as follows. Asthma is a chronic inflammatory disorder of the airways in which many cells and cellular elements play a role, in particular mast cells, eosinophils, neutrophils, especially in sudden onset fatal exacerbations, occupational asthma, and patients who smoke. T lymphocytes, macrophages, and epithelial cells. In susceptible individuals, this inflammation causes recurring episodes of coughing, particularly in the night or early in the morning. Wheezing, breathlessness, and chest tightness. These episodes are usually associated with widespread but variable airflow obstruction that is often reversible either spontaneously or with treatment. Airflow limitation is caused by a variety of changes in the airway. All are influenced by airway inflammation. Bronchoconstriction is where the bronchial smooth muscle contraction that quickly narrows the airways in response to exposure to a variety of stimuli, including allergens and irritants. Airway hyperresponsiveness is an exaggerated bronchoconstrictor response to stimuli. In airway edema, as disease becomes more persistent and inflammation becomes more progressive, edema, mucus, hypersecretions, and formation of incapacitated mucus plugs further limit airflow. Now, remodeling of the airways may occur. Reversibility of airway limitation may be incomplete in some patients. Persistent changes in airway structure occur, including subbasement fibrosis, mucus hypersecretion, injury to the epithelial cells, smooth muscle hypertrophy, and angiogenesis. Now we're going to talk about some of the causes of asthma. So some of the causes of asthma, the development of asthma appears to involve the interplay between host factors, particularly genetics and environmental exposures that occur at a crucial time in development of the immune system. The definitive cause of inflammatory process leading to asthma has not yet been established. So we're going to talk about innate immunity. Numerous factors might affect the balance between the Th1 type and the Th2 type cytokine response in early life and increase the likelihood that the immune response will down-regulate the Th1 immune response that fights infection. Instead, will be dominated by Th2 cells, leading to the expression of allergic diseases and asthma. Genetics can cause asthma. Asthma has been an inheritable component, but the genetics involved remain very complex. Another cause is environmental factors. Two major factors are the most important in the development and persistence and possibility of severity of asthma. One is airborne allergens, particularly sensitization and exposure to house dust mite and Altonara, and viral respiratory infections such as RSV and the rhinovirus. Other environmental factors are understudied, such as tobacco smoke while pregnant, and they say that tobacco smoke increases wheezing, but it is not certain that this is linked to subsequent development of asthma. Also, air pollution due to the ozone that can contribute to asthma. But again, studies are still being created and trials are still being investigated. So now we're going to talk about basic roles of medications. So the first one I'm going to talk about is the quick relief medications. Quick relief medications, short acting beta 2 agonists, relax airway muscles to provide prompt relief of symptoms. Do not expect them to provide long term asthma control. Using a short acting beta 2 agonist for more than 2 days a week indicates the need for starting or increasing long term control medication. So now we're going to talk about long term control medications. They are used to prevent symptoms, often by reducing inflammation. They may be taken daily, but do not expect for them to provide quick relief. So now we're going to talk about the optimal technique for specific patient populations. So let's start off with talking about the DPIs, which is a dry powdered inhaler. It's typically used in ages greater than 5 years old. The optimal technique is rapid, 1 to 2 seconds, or 60 liters per minute. Deep inhalation, minimally effective inspiratory flow is device dependent. Most children less than 4 years of age may not generate sufficient inspiratory flow to activate the inhaler. Therapeutic issues, doses lost if patient exhales through the device after actuating. Delivery may be greater or lesser than an MDI depending on device and the technique. Delivery is more flow dependent in devices with highest internal resistance. Rapid inhalation promotes greater disposition and larger central airways. Mouthwashing and spitting is effective in reducing amount of drug swallowed and absorbed. Now, let's talk about an MDI with a chamber. So you want to use it for ages greater than 4 years of age. If they're less than 4 years of age, you will want to add a face mask to the chamber. So it's slow, 3 to 5 seconds. A deep inhalation followed by a 10-second breath hold immediately following actuation. Actuate only once into the spacer per inhalation. If face mask is used, have a tight fit and allow 3 to 5 inhalations per actuation. You want to rinse the plastic VHC once a month with low concentration of liquid household dishwashing detergent. Some therapeutic issues. Indicated for patients who have difficulty performing adequate MDI technique, may be bulky. Simple tubes do not alleviate coordinating actuation and inhalation. The VACs are preferred. Face mask allows MDIs to be used with the small children. However, use of a face mask may reduce delivery of drugs to the lung by 50%. So this is when you're using a spacer or a valve holding chamber. So using an MDI without one, without a spacer, you want your patient to be greater than 5 years of age. Make sure they have a tight seal around the mouthpiece and slightly more than rapid inhalation than a standard MDI, followed by a 10-second breath hold. So now we're talking about the breath actuated MDI. May be particularly useful for patients unable to coordinate inhalation and actuation. May also be useful for elderly patients. Patients may incorrectly stop inhalation and actuation and cannot be used with currently available spacer valve hold masks. Now, a regular MDI is indicated for people greater than 5 years of age. Evacuation during a slow 3 to 5 seconds. Deep inhalation followed by a 10-second breath hold. Some therapeutic issues that come along with the MDI inhaler with slow inhalation and coordination of evacuation during inhalation may be difficult, particularly in young children and elderly. Patients may incorrectly stop inhalation at evacuation. Disposition of 50 to 80% of actuated dose in the oropharynx. Mouthwashing and spitting is effective in reducing the amount of drug swallowed and absorbed systemically. Long delivery under ideal conditions varies significantly between MDIs due to differences in formulation versus hydrofluorocane. For example, inhaled corticosteroid delivery varies from 5 to 50%. So last we're going to talk about the small volume nebulizer with a mask or a mouthpiece. Patients of any age can use this. With a face mask. The optimal technique will be slow tidal breathing with occasional deep breaths, tight-fitting face mask for those unable to use the mouthpiece. Using a blow-by technique, holding the mask or open tube near the infant's nose and mouth is not appropriate. Therapeutic issue, less dependent on patient coordination and cooperation. Delivery method of choice for cromolyn sodium in young children. May be expensive, time-consuming, bulky, output dependent on a device and operating parameters, feel, drive gas flow. Use of a face mask reduces delivery to the lungs by 50%. Nebulizers are as effective as MDIs plus VHCs for delivering bronchodilators in the emergency department for mild to moderate exacerbations. Data in severe exacerbations are limited. Choice of delivery system is dependent on resources, availability, and clinical judgment of the clinician caring for the patient. You have potential for bacterial infections if not cleaned properly. So there are many ways that you could identify and avoid environmental exposures. You can identify your environmental allergies due to an allergy test that is performed by a doctor that can actually pinpoint which allergies bother you and trigger your asthma exacerbations. So some techniques on how to avoid environmental exposures. So for instance, if you have indoor mold, you will want to fix leaking faucets, pipes, or other sources of water, clean the moldy surfaces, dehumidify basements if possible. If you have, like some people are allergic to the flakes of skin or dried saliva from animals, the best thing to do is keep pets or fur out of your home. If you can't keep pets outdoors, then keep them out of the bedroom and keep the bedroom door closed. Remove carpets and furniture covered with cloth from your home. If that is not possible, keep the pet out of the rooms where these are. For pollen and outdoors, during your allergy season, when pollen counts and counts are high, you want to try to keep your windows closed. If possible, stay indoors with windows closed during the midday and afternoon if you can. Pollen and some mold spore counts are highest at that time. Ask your doctor whether you need to take or increase anti-inflammatory medication before your allergy season starts. Smoke and strong odors and sprays. So if possible, do not use wood burning stoves, kerosene, heaters, or fireplace, unvented gas stove, or heater. Try to stay away from strong odors and sprays such as perfume, talcum powder, hairspray, paints, new carpet, and particle board. Other things that can make asthma worse is cold air. So cover your nose and mouth with a scarf on a cold, windy day. Another thing is self-monitoring is very important. So you always want to make sure that you do use your peak flow meter. And if you're not at your best, then you know that you need to seek medical attention. The clinician and the patient should develop and review the action plan to make sure that it's fit for the quality of life of the patient.